welcome to February Grand Round. I'm Heather, the Regional Research and Education Coordinator. So thank you for coming today. We're going to get started so we'll have enough time for Stephanie's presentation. So for those of you that don't know Stephanie, Stephanie Moulton is a pharmacist who works part-time here in oncology at the St. John Regional Hospital and also works as a pharmacist in Hampton at the Hampton Pharmacy. She's also working on her PharmD right now, so it's very busy. Stephanie for presenting today. So she'll be walking us through what we need to know about oral chemotherapy. I'll hand it over to you. Don't bring up your
slide. Okay. So thank you everyone for coming. And today I'm going to give you a very brief, or I guess how the experts are coming in. So. I'm giving you a brief overview about systemic oral chemotherapy. And I'm just really, these are the basics. So I don't have any disclosures other than the fact that I'm very new at this. So I feel that I am an expert in my presentation and what I'm hoping to accomplish, which I'll get into a little bit later. But if there are any specifics or any real drug questions, I may have to pass you off to some of the experts that just walked in that work in the PO clinic. So the objectives are to describe the services provided by the oral systemic chemotherapy clinic here at the regional, to describe the most frequently used oral systemic chemotherapy agents, their precautions and adverse effects. We're going to review the oral systemic chemotherapy protocol calculations and talk about appropriate references for finding this information, and we'll also review some common drug interactions and approach to management. So the purpose of this presentation, as Heather mentioned, I am studying for my PharmD right now. I'm almost done. And as part of the requirements for completion, we have to do some clinical practice activities. So the criteria for this clinical practice activity was we had to find something, an area where there could be patient care by a pharmacist intervention. So because I've worked in community pharmacy for so long, and then I just started in oncology, I really recognize that there's some gaps in knowledge, and also maybe there's some ways that we can work together between hospital pharmacists and community pharmacists to improve patient care. So the purpose of my clinical practice activity was to develop an activity, an education program mainly for community pharmacists to help them learn more about oral chemotherapy so that they would be more familiar with it, more comfortable, and raise their level of confidence, but also to help them learn about what's going on here at the regional, because I found in community I didn't really know everything that was going on. And also was to help the PO clinic, because there's some things that I think community pharmacists can do to help them. But in the meantime, I've condensed my presentation into a shorter little period, and hopefully you guys can get something out of some of the work that I've done. So oral systemic chemotherapy agents, they're being approved at exponential rates. And many patients find them quite convenient, but they do require education and monitoring. So what happens at the PO oncology clinic here? Well, the oncologist will assess the patient, and if they find that they're suitable for some therapy, then they'll place a consult to the outpatient oncology pharmacist. The pharmacist will review the protocol note for appropriateness, and then medications are screened for drug interactions with chemotherapy. And all along this continuum, the prescriber is alerted if there are any issues or concerns. So what kind of teaching do they get? Well, they get some information from the BC Cancer Association or Cancer Care Ontario, which I'll talk about a little bit in more detail a little bit further. They'll get some points to remember. They'll get a yellow card So does everyone know what the yellow card is? Are people familiar with this? Okay. So because some of these medications can cause some neutropenia and that sort of thing, if they get a fever, it's a medical emergency. So they're told to go directly to the emergency room. And they're all given this card, and this gives them a bypass the line. They hand this to the triage nurse, and off they go, and they're seen immediately. Then they learn a little bit about safe handling, and they'll bring in their actual prescriptions that they've had filled at the community pharmacy, and the pharmacist will go over that and make sure that everything's there, that everything's filled correctly, that the directions are clear. And then a calendar will be created for the patient, and their appointments and their doctor's appointments and their blood work appointments and that sort of thing will be noted on the calendar. And then the pharmacist will continue to follow them, and when their blood work, when they know blood work is due, they'll look at that and make sure that the patient is ready to go on and do their next cycle if the oral chemotherapy. So we're going to look at a case study, and I took this directly from the BC Cancer site. So PN, she's a 76-year-old female, and she has adenocarcinoma of the colon and metastatic to the liver. They've determined that 5-FU is not suitable for this patient, so they're going to give her protocol that I've listed there. So there's her vital, her information, her height and her weight, and some labs. So I just want to talk about that protocol for a moment. So when you see these protocols, they're broken up. So the first two letters would indicate the tumor site. In this case, the AV would mean advanced. And because of the treatment that she's going to be on, CAP refers to the drug that she's going to be on. So when you look at the protocol notes and they have those funny names, usually it makes sense if you can break it down that way. So we want to know, is this therapy appropriate? And so we'll look at the protocol. And the protocol for the people that work at the regional, you can always, if you're screening or that sort of thing, you can always look on I3 and you can find the actual protocol note if you want to double check what it is, if you want to double check the height and weight and that sort of thing. But if you look under BC Cancer, and I've listed the website there, there will be protocols there, the cancer protocols. So you find the appropriate one. And there's also Cancer Care Ontario. Now, there are other places we may look to, depending on the circumstance, or we may have to look at studies or trials or that sort of thing. But these are the two main references that we would use. And another reference that I haven't listed here, but it's really good if you're looking for side effects and that sort of thing, it's called On Target. So here's the protocol. And in BC Cancer, it states what it's used for: first-line metastatic or unresectable colorectal adenocarcinoma. And so this describes our patient exactly. So yeah, the protocol seems right. So as far as the dose, again, we go to BCCA, and they recommend 1,000 to 1,250 milligrams per meter squared, BID. And it'll go for 14 days. And the starting dose, they also say, for elderly or poor performance status or extensively pre-treated patients, they recommend to start at the 1,000 milligram per meter squared dose. So remember, our patient is 76. And you have to also keep in mind what dosage the tablets come in, because this is oral. So you're kind of limited if the dose works out to a different amount. It's not like we can add an extra mil or that sort of thing. You have to work around the tablets that are available to you. And then you repeat every 21 days for a maximum of 16 cycles. Most cytotoxic chemotherapy doses are based on body surface area. And the Musteller formula is usually the formula that we would use to calculate the dose. We usually use actual body weight. Doses may be capped, not usually for weight, but maybe because of some toxicities or hepatic or renal problems. So in this case, we calculate the dose. It works out to 1.97 meters squared. We've looked at the creatinine clearance because we want to know how are her kidneys, and in this case, they're not too bad. So because she's elderly, we're going to go with the 1,000 milligram dose, and so we get 1970 milligrams. And so we'll round that up to 2,000, and she'll get 4 of the 500 milligram tablets twice a day. If there is a dose discrepancy, we'll allow 5%, but if there's other than that, if the oncologist has come up with something that's not within that, always contact the provider. So if you're screening on a Saturday or something and you get an oral chemotherapy agent and you're not sure about the dose or that sort of thing, this is where you can go to look at the dose. So as we learn more about the disease, the pathophysiology of cancer, there have been improvements or a lot of different options in the treatment of chemotherapy. So oral chemotherapy is not new. It's been around since the 1950s, and there are plenty of agents that have been around since that time. They were mostly alkylating agents and antimetabolites. Then as we went on, we came up, found some, discovered hormonal therapy, and then developed an anti-androgen. And then in the 2000s is when targeted therapy started to become available, and there's been a boom since the targeted therapies are around. But we still use a wide variety of all the different agents, just that the targeted therapy is becoming more and more common. So the mechanism of action of the alkylating agents, they interfere with the various phases of the cell cycle, and which leads to cell death. So the problem with this is it gets the tumor cells, but it also impacts so many of the healthy cells. So you get many toxicities: nausea, vomiting, diarrhea, mucositis, myelosuppression, and then the renal and hepatic toxicity. Hormonal agent for breast and prostate cancer, the toxicities would be what you would expect if you're messing around with the hormones in your body. So hot flashes, irregular menstrual bleeding, vaginal dryness, impotence, decreased libido, for example. And then, as I said, as we understand how cancer works more and more, and we have a better understanding of signaling pathways and tumor markers and cell biology, we discovered the targeted therapies, and they can work on proteins and pathways, and they can work more directly on the tumor cell and not affect the healthy cells as much. So some examples of oral targeted therapy would be tyrosine kinase inhibitors. They block enzymes from sending signals to cause a cancer cell to grow. Imatinib would be an example of that. There's angiogenesis inhibitors, and they prevent new blood vessels from growing, so they cut off the blood supply to the tumor, and often attaches to the vascular endothelial growth factor, so you'll hear about VEGF, receptor protein on cells, bosutinib. There's CDK4/6 inhibitors. Blocking this protein will help prevent cell proliferation. And mTOR inhibitors also block proteins that are responsible for cell replication and division. So these are probably some of the most commonly seen agents in the PO clinic here. And you can see I have the generic name and the brand name and the class and their indication for the BC cancer protocols. Oh. True or false? Oral systemic chemotherapy is less toxic and easier to take than traditional parenteral therapy. So you have people I know in the community, they'll say, oh, this friend has cancer, this friend has cancer. One of them has to go into the regional 3 days a week, and she is hooked up to an infusion for multiple hours, and so she's really sick, and she's on chemotherapy. But this other friend, she has breast cancer. She's just taking this pill, so it's really, she's not as sick, or she doesn't have as potent as a treatment. But oral chemo is not innocuous, and so people have to remember that, and their caregivers have to remember that. Luckily, adverse effects are often predictable based upon the mechanism of action, so we can hopefully prevent some of them or help people manage them. And this prevention and management is essential because we want to make their quality of life tolerable while they're going through this therapy. And we also want to make sure they're going to comply with the therapy and finish it. So diarrhea can occur up to 60% or more in targeted agents. The TKIs are pretty frequent offenders for that. And it may be dose limiting. They may have to change the dose depending on the patient's tolerance. Often these patients are on multiple agents. They might be on parenteral therapy and oral therapy or two oral therapies. So that can make it worse by having these multiple agents involved. So traditional chemotherapy, when I talk about traditional therapy, I mean the older ones, the alkylating agents and that sort of thing. They're directly toxic to the epithelium. And targeted therapy, we're not exactly sure the mechanism of the diarrhea, but it could be due to increased expression of the EGFR in the intestinal goblet cells or things that lead to this increased prokinetic activity. So the toxicities are all graded from 1 to 4, 1 being the least bothersome, although it's still serious, up to 4, which could be life-threatening. So in diarrhea, less than 4 stools a day over baseline would be grade 1, and grade 4 would be dehydration, electrolyte imbalances. So what can we do? Well, avoid food and triggers that can aggravate it, certain foods, dairy products, that sort of thing. Identify medications that may contribute. So if someone's admitted to the hospital, they may be put on a bowel regimen, they go home, 3 months later they're still on the bowel regimen, and I find that a lot in the community. So someone will come in and they talk about their mother has diarrhea, and you talk about their medications they're on, well, they're on PEG or something like that. So just always look at their profile and see maybe there's some obvious cause to their diarrhea, and it's not necessarily the medication. But if they do need to be treated, you can use loperamide. Unresolved grade 2 or higher diarrhea must be reported to the physician, and as I said, dose adjustment may be necessary, and always monitor the electrolytes. Hand-foot syndrome is a toxic erythema of the palms and soles due to chemotherapy. Capecitabine and TKIs are known for this. It seems to often be dose-related, so both cumulative doses or peak doses. So signs and symptoms would be tingling sensations in the palms and soles. There could be edema with tender symmetrical erythema over the fat pads of the fingers and toes. It can lead to blistering and desquamation, and there could be thickened, painful hyperkeratotic. So here's an example of what it looks like, and it can be quite angry and painful and just not very good for quality of life. It can disrupt their movement. They can't walk, they can't do certain things, and the grades are listed there. So in order to prevent it, we want to reduce friction. So don't wear tight gloves or tight footwear, and don't go out in the garden if at all possible with tools that you're using repetitively. So you can use cotton gloves and socks with emollients. Avoid putting your hands or feet in hot water for long periods of time. You might want to use some ice packs, or you might need to be treated with topical steroids. Pain management, so acetaminophen would be usually what we would recommend. And again, on all of them, always you may have to adjust the dose. So always keep this in mind. If you have a patient that's presenting with this type of thing, then it could be related to their chemotherapy and they need dose adjustment. The provider might need to contact. EGFR inhibitor rashes, erlotinib, afatinib are commonly cause these in up to 80% of patients. There's a papulopustular rash, mucositis, fissures. There could be an acneiform rash, and it usually appears in the first 2 to 4 weeks of therapy. Risk factors seem to be non-smoker, fair complexion, older than 70 years old. Prevention is steroid cream. Moisturizer is very important, and sunscreen is really important. Sometimes you might need to use some doxy or minocycline to treat, and again, dose adjustment. So there's, again, what it looks like, and the people can feel quite self-conscious if they have it. Plus, it can be very uncomfortable. So our favorite prolongation. Many oral chemotherapy and the supportive care agents can prolong the QT interval, KI. And so we all know the risk factors: congenital lung syndrome, elderly, female, MI, or taking multiple drugs that prolong QTC. And our chemo patients often are on a lot of drugs. They may be on an antidepressant, an anti-nauseant, and their chemo drugs. So quite often they are on medications that prolong this interval. So just always be cognizant of the drug interaction. Minimize their concurrent prolonging QTC medications if you can. Take a look at their profile. Do they still need to be on this medication? And discontinue the offending agent, manage their electrolyte, monitor safety if necessary, and if you need to, dose reduce. So mucositis it also can have a very significant impact on daily function and their nutrition. They're already maybe deficient in their nutrients, and now they're not able to, and their quality of life. And I find in community a lot of people come in with this problem and are having and they might be looking for boost or something that they can eat because their mouths are so sore. So it can range from mild inflammation to bleeding ulceration. And it seems to progress in a stepwise fashion. So for 0 to 5 days after therapy, they might be asymptomatic. There might be some redness or erythema. And then up to 7 days after, they might get some desquamation in little white patches. And then 6 to 12 days, they'll get some contiguous membrane. And then 12 to 16 days after therapy is when you can get really painful lesions, and there may or may not be ulceration. And there's some oral agents that can be responsible for causing this toxicity. So if we can prevent it, again, that's great. So we tell them to avoid rough food, that sort of thing. Salty, spicy food, use a soft bristle toothbrush. Avoid smoking and also alcohol-containing mouthwashes. Good oral hygiene. Keep the lips and mouth moist. Drink with water every couple of hours. You could add salt or baking soda to the water, and you might want to alternate those. So the treatment would be pain management, mouthwashes like Magic Mouthwash, and depending on their level of compromisement, they might need some antivirals or antifungals or antibacterials. And it's important to avoid liquid medications containing alcohol. So sometimes you will get a physician that says, okay, this person is having difficulty with their mouth, so we're going to change this pill to a liquid. And then you look at the the alcohol content of the liquid, and it's 30%. So just make sure when you're dispensing those liquids that you have that in mind. But you want to avoid the alcohol and the drying effect. Another problem you can see is coagulopathies. They can cause, some oral chemotherapy can cause increased bleeding, others cause clotting, are at risk for clotting. So screen the patient for individual clotting and risk factors, or clotting and bleeding factors. And some patients might need current PE prophylaxis. Their profile, are they on ASA? Why are they on ASA? Do they need it? And look if they're on oral anticoagulant, and make sure you keep this all in the back of your mind when you're giving them their care. So drug interactions, there can be quite a few of those as well. And absorption of many oral chemotherapy agents is pH dependent. And so acid suppressants can reduce the bioavailability because of it. So screen the patient for acid suppressing therapies. And now there's so many over-the-counter ones that you might not even know the patient is taking. Before, you would see that they were on a PPI, but now they might be getting their Nexium over-the-counter. It's over-the-counter now. So just always make sure, as pharmacists do, that you ask them, are you on anything else? Are you taking anything over-the-counter? So there's just a list of some of the agents and the effects that they can have. So CYP450 interactions. So a lot of these agents are taken chronically, and the patients are often elderly with comorbidities and multiple medications, and that puts them at increased risk of drug interaction. And most of the new oral targeted therapies are metabolized by the CYP450 enzymes in the liver, so they're highly susceptible to the drug-drug interaction. And concurrent inhibitors and inducers may lead to reduced efficacy or increased toxicity. So they're not going to get the benefit of the drug, or they're going to have some difficulties. So again, this is another thing that we have to look for, because getting back to what people are thinking about these pills, they are serious, and some of these drug-drug interactions can lead to life-threatening toxicity or therapeutic failure, which is also just as bad. And there's also drug-food interactions. The chemotherapy absorption rates can vary based on food intake. So the absorption rates are different for each drug. You have to check each drug separately. So for example, lapatinib you take on an empty stomach because food increases the AUC fourfold, and capecitabine take with water 30 minutes after a meal, and food decreases the AUC by 35% on that. So always refer to the monograph to make sure that you get it correct. And then, of course, another drug-food interaction is grapefruit, and that goes back to how it's metabolized. So there's another example of when to give the medication with or without food. And so that's something another thing when you're screening, or if you have patients on the floor, you might want to make sure that the nurses have put the administration in at the appropriate time, the same time that they've been doing it at home, or what the pharmacist or the physician has recommended to them. So if we go back to our case, all her information again, just to do a little refresher. So we checked, the dose is good. The duration of the treatment and cycle interval, that was good. We checked that out with the protocol also. So if you look under the BCCA guide, it will tell you, and you go on a stepwise fashion when you're screening these medications. So you want to review their lab. You want to make sure, do they have any pre-existing disease? Do they have any chemotherapy and toxicity? So do they have any liver dysfunction right now, or hematological or renal dysfunction? And make sure that you need to modify the dose. So in her case, her LFTs are elevated. And if you remember, she had liver met. So we would expect them to be elevated. And if you look in the BCCA, the dosage in hepatic failure, it says no dose adjustment is required with mild to moderate hepatic dysfunction due to liver metastases, and although they have not done studies in severe. So it's very clear, the protocols are written so nice and clearly that it's easy to tell, to have good direction of what you're supposed to do. So after the fourth cycle of her capecitabine, she gets some healing, redness, and pain on both of her hands. And she has grade 3 hand-foot syndrome. So her subsequent doses are delayed, and then they are going to reduce the dosage. So symptoms resolved, it's time for her to start again. There are her labs. So you look at the dose modifications listed on PCA, and you see that it should be reduced to 75%. And so she had 2,000 milligrams initially, so we're going to take her down to 1,500 milligrams. So this is what it looks like in PCA. As you can see, it very clearly tells you, based on the grade, how many events they've had and that sort of thing. Gives you some guidance so that you're not completely blind when you're deciding whether what the oncologist is doing seems appropriate, or if you're trying to give some direction to someone. So she's also on pantoprazole, warfarin, and metoprolol. So is this a problem? Well, if you look, we talked about the proton pump inhibitors, and in this case with this medication, it may reduce the pharmacological effect. So do we care about that? Well, in this case, PCCA says the clinical significance is unclear. So it may not need to do an intervention, but if you want to be cautious, you could maybe see if she needs that PPI, or maybe she could use something else and adjust the timing. And she's on warfarin, and this medication really can increase the chance of bleeding. So it's important to make sure that our INR is monitored regularly. So then we also have to monitor the treatment progress. So we look at the labs, make sure that there's supportive care is in place, and adherence is really, really important. These people, it's not always an easy schedule to take their medication. They have to remember when to take it. It's not necessarily one every day. And they may have a lot of other pills they're taking. You have to remember they have this diagnosis, so they may be depressed. They may be having difficulty paying for the medication, or the pharmacy may not be getting it in on time for them, and that's something they have to struggle with. So sometimes adherence can be a real struggle. And then if you look at a study, it showed that imatinib and CML, patients had an adherence rate, patients with an adherence rate less than or equal to 85% had a 26.8% probability of losing complete cytogenic response at 2 years. And so I look at in the community, some of our patients, and I think 85% adherence is pretty good, honestly. I know we want higher, but to be realistic, so it just goes to show that it's really important that they have to have better than 85% adherence if they're going to maintain the positive effects they're receiving from these therapies. And also remember to recognize the treatment issues, toxicities as soon as possible. So also remember these medications are most likely cytotoxic or cause some ill effects if they're not handled properly or in the right people. So always stress the proper storage and handling precautions in the community. Use a different pill tray if you're counting these pills. And again, remember to tell people to treat this special. And the nurses on the floors and that sort of thing, they might not know what the medication is when they come in, and they just pop it out and give it to the person. And they have to take everything, make sure they're paying attention. And so education is the key to that again. So just to conclude, oral systemic chemotherapy is becoming more and more common. If you watch TV at all, I know at least once a day it seems like there's a commercial for some type of chemotherapy medication on the television. They're potent. They're as potent as traditional parenteral therapies. CC Cancer and Cancer Care Ontario provide thorough instructions about each agent protocol, and pharmacists play a vital role in identifying and managing drug interactions. Pharmacists here their research regarding systemic oral chemotherapy. Yeah, does anybody have any questions?
Hello, yes, I have question.
Yeah.
Yes, my question is, thank you for the presentation, but because for non-specialized pharmacist, did you go through, for example, like a checklist for every medication? Have you seen something like a resource to see, for example, for this medication, you can check labs, check certain types of labs. For example, you need to make sure the liver function is normal, or white blood count is normal, or for example in biologics, say the patient did the like TB test, PPD test, like these things to like I would say, like, if did you see like a resource show checklist for every chemo medication to help for decision making, for example community pharmacists
In community pharmacy, do we?
or even non-specialized pharmacists, when, for example, if I am non-specialized pharmacist in oncology and I have this checklist like for every medication in terms of labs, in terms of certain drug interaction, or in terms of certain precaution, like as I mentioned, TP done for biologics. So this maybe help to figure out any problem expected. For example, if like Dr. Robertson, the patient had an echo, like these things.
Mm-hmm.
So
yeah. So with our parenteral therapy, yes, we have certain checklists or criteria that we go through on each and every patient. We check everyone before we mix it and before the patient gets it. And in the PO clinic, I would say you pretty much do the same thing. Would you say?
Yeah, so when we teach on a pill, we're usually looking at the instructions that the physician has laid out. So like certain pills have certain things that you want to be checking. So whether it's like a lymphatic where you want to be checking the blood pressure, make sure that those things are scheduled to be monitored.
Yeah.
Well.
And then as far as community pharmacy, that's where it's all over the map. And I would say in most cases, not enough is done. And so that's what my project is. Hopefully we'll be able to address that.
Yes, I agree with you, mainly in the community. Yes, with IV, I know there is a checklist, but mainly with PO, if there is like a checklist for the pharmacist to go through it, it will be more safer and more effective as well to dispense the medication.
Yeah, and another resource that I didn't mention in this presentation, but it's really good if you look on Nova Scotia, Cancer Nova Scotia. They've been doing some work there, and they do have an oral toolkit that you can look, and it's got some of the medication. So if you are in community or if you're in screening here in the pharmacy, you can check this toolkit, and it will make sure that you're covering most of your bases. But also you can go look in each monograph too.
Thank you.
You're welcome.
Stephanie, it's Mike LeBlanc Moncton. How are you?
Good. How are you?
Good, thank you. I just wanted to follow up on that comment. The other tool that will be maybe somewhat useful for more the novice oncology practitioner is something called Oncology Basics from CAFO. Mm-hmm. And that actually is in the very middle of being completely rewritten with the addition of a number of new oral therapies that, I mean, it's not obviously not complete, and it doesn't go into the details of the BC Cancer Agency or CCO or even CCNS with respect to what to monitor and when. That still very much needs to be developed, I think, for a number of different reasons, both for community and for the hospital practitioners. But the Oncology Basics is a really good starter. That can be used as a resource somewhat in the way that Haney was referring to.
Mm-hmm. Yes, it is very good.
I have a question about the PPIs.
Mm-hmm.
You've been talking about, Stephanie. So, because it can decrease the concentration of some of these oral agents, have you guys ever stopped somebody's PPI or switched them to something else?
Yeah, I think that happens quite frequently. Yeah, it does.
Usually it's a discussion with the physician and with the patient, like what their symptoms are, how long they've been on it, what else they've tried, what's worked, that sort of thing, and then with the physician based on whether they're curative or palliative or things like that.
Yeah. And if you look at PPIs in general, we all know they are so overprescribed, and a lot of the times the patient doesn't even really need them. So you can go on a case-by-case basis.
How long are people on the oral chemo agents? Does it depend based on the type of cancer?
It does, yeah. Some people, would you say, are there lifetime ones?
On the metastatics are usually until their disease progresses, so they have toxicity.
Yeah.
So yeah, the majority of them.
Well, some of the capecitabines are shorter term, but yeah, just like 8 cycles or whatever. But a lot of the metastatic disease will continue until.
Yeah. So that's another thing, like you say, you kind of get complacent. If you've been taking it for months and months and years, you may forget how serious and this is a potent medication.
Any questions from the other site? Fredericton, Moncton.
I have a question. So we have like a form here. We just did, but the cancer pharmacist who came in and did our whole program kind of stated that there's some points where she'll walk in and there's a new chemo medication that hasn't even gone through clinical trials and it's brand new. There's barely a monograph. How do you kind of deal with that in the sense that you don't really know interactions because there really hasn't been tests?
So, do one of you want to talk about that? Yeah.
So
There's.
biggest drugs that aren't necessarily like approved by the government or by formulary or whatever, and a lot of them come through. We have a reimbursement coordinator in oncology, so she kind of gets the special drugs in. Usually there's at least a little bit of information, like whether it's a US like FDA monograph or something like that, and you can kind of pull information from that. Again, you can't necessarily check like your normal interaction resources out there, but you can kind of pull from that monograph to be able to get some semblance of what's going on.
And that's where there may be a trial or something that you might have to read. So it's not as nice and in a nice little compact way like BC Cancer, but you can get the information.
Thank you very much, Steph. Really appreciate it. So for those of you who signed on through Skype, if you guys could either fax me or email me your attendance to let me know so I can track our numbers, and I'll send out an evaluation after lunch for people to fill out. So thanks so much, and we'll see you in a couple weeks for Pharmacy Journal Club.
Thanks for everyone's attention.